Ultrasound Academy. It's an institution for dedicated ultrasound training located in Pimpri Chinchwad area in Pune. Hands-on training is given at KR Diagnostic Center, Bhakti Sonography Clinic and Sri Mauli Diagnostic Services LLP in PCMC area. Training is given by highly professional radiologists with more than 10 to 15 years of experience in the field of ultrasound. Training covers all aspects of ultrasound such as emergency, pediatric, gynecology, small part, OBS ultrasound, fetal medicine as well as invasive procedures under direct supervision of professionals. Personal level attention from faculties. Sufficient number of good quality ultrasound machines for training. Detailed teaching program with lecture series upon basic anatomy, scanning techniques, interesting cases, etc. Lectures from invited faculties, separate conference hall with AV facilities, complimentary FMM certification, separate WhatsApp group for academic students for academic discussion, and access to huge collection of well-documented ultrasound cases from archives of faculties.
I'll start my presentation. Can you all see image on the slide? Is it normal or abnormal? Can anybody please tell me in the comment box? Unable to see chat box, but I think all of you know this is abnormal three chamber view, three vessel view. We can see one extra vessel here, right? Whenever we see one extra vessel in the three vessel trachea view, we all have DDs like PLSVC common, then TAPVC, and there can also be PAPVC. Okay, so my today's topic is anomalous pulmonary venous connections. I'm Dr. Pranali Patil. I have done my MBBS and DMRE and was a fellow at Ultrasound Academy. My guides are Dr. Nitin Jadhav sir, Dr. Yogesh Chaudhary sir, and Dr. Varun Kapoor sir. In normal conditions, all four pulmonary veins drain into left atrium. In anomalous condition, 1 to 4 veins drain directly or indirectly in right atrium, leading to partial APVC or total APVC. It is rare congenital cyanotic heart disease with very less antenatal detection rate, but antenatally detected cases carry favorable prognosis. Most cases are missed prenatally as diagnosis is difficult until recently with improved ultrasound technology as isolated or part of heterotaxis syndrome. It is common in primarily right isomerism. In non-heterotaxis syndromes, PAPVC can be isolated or with other complex cardiac anomalies like AVSD, TGA, pulmonary stenosis, double outlet right ventricle, or coarctation of aorta. Chromosomal abnormalities are uncommon with TAPVC. Hemodynamic consequences are significant to neonate as degree of mixing of pulmonary and systemic blood leads to cyanosis. We'll go shortly through embryology. In the first month of gestation, primitive cardinal and umbilicovitelline veins bring systemic circulation into fetal heart. This is right common cardinal vein. This is left common cardinal vein. These are lung bursts, right and left lung bursts. So initially during 27 to 29 days of conception, pulmonary venous plexus arises from splanchnic plexus. This is splanchnic plexus. Pulmonary venous plexus arises from this. Then embryological left atrium gives rise to common pulmonary vein. This common pulmonary vein merges with venous plexus and splits into four and then is incorporated in walls of left atrium. Failure of common pulmonary veins to merge with venous plexus results in TAPVC. There are total four types of TAPVC. Most common is supracardiac, then cardiac, infracardiac, and mixed type, which is least common type. Supracardiac TAPVC, it is commonest, in which four-chamber view is normal in many cases. However, right chambers of heart appear dilated as compared to left in few cases in advanced gestation. Four vessels are seen in three-vessel trachea view. Outflow tracts are normal in most of the cases. All pulmonary veins do not open in left atrium. However, they join to form a confluent vein behind left atrium. This is known as Twick's sign. Confluent vein opens in vertical vein, then into left brachiocephalic vein, and then into SVC. That's why SVC also appears dilated. Retrocardiac space is also increased. Pectoral Doppler over vertical vein and left brachiocephalic veins show waveforms similar to pulmonary veins. We'll see in next images and scene. Okay. On the left side, we can see normal heart. This is left atrium, left ventricle, right atrium, right ventricle. Pulmonary veins normally open separately in left atrium. In supracardiac TAPVC, pulmonary veins join to form confluence behind left atrium. This confluence open in vertical vein, which then drains in left brachiocephalic vein, which drains in SVC and ultimately right atrium. Okay. Now we will go for cases. This is anomaly scan at 20 weeks. Like we saw the first slide of the presentation, this here is the abnormal extra vessel in the in this section. Also notice color difference in two vessels because what are our DDs? It was PLSVC is also one of the DDs for the extra vessel. But if it was PLSVC, color would be same in SVC and the extra persistent vessel. Here we can see opposite colors in this. Now this is inferior pulmonary vein joining forming a confluence behind atria. Also notice spectral waveforms is similar. Waveform in the confluent vein is similar to pulmonary veins. This is vertical vein and brachiocephalic vein. This will be better seen in the CNAs. This is vertical vein. This is SVC. Okay, this is lateral four chamber view of the heart. Okay, note this is extra vertical vein seen here, uh, draining into left brachiocephalic vein. This is confluent vein formed by inferior pulmonary veins behind atria. Okay. So dilated left brachiocephalic vein also SVC also appears dilated because of drainage from left brachiocephalic. Here this is colored scene of the same. We'll see the bookmarks. This is confluent vein. Here is vertical vein. Notice color difference in two vessels. SVC and TAPVC, vertical vein of TAPVC shows opposite colors. This is dilated left brachiocephalic vein. This is low scene of the same. Here we can appreciate it better. This vessel is seen behind atria. This is a vertical vein joining left brachiocephalic. This, so dilated left brachiocephalic and SVC. So this diagnosis was given as a supracardiac type of TAPVC. The parents did a second, they took second opinion. The diagnosis was confirmed and the pregnancy was terminated. This is another case. A patient came for anomaly scan at 20 weeks, 4 days of gestation. Again, similarly, this is apical four chamber view of the heart, grossly appears normal. In three vessel view, this small extra vessel is seen draining in the left brachiocephalic, like the first case only. Here we can see this is pulmonary artery, aorta, and SVC, and this is vertical vein. Normally, what is the order of sizes of these vessels? Largest is the pulmonary artery, then aorta, and then smallest is SVC. But here, SVC appears as large as aorta. They are almost of equal size, like pulmonary artery and aorta. So, because it is getting extra drainage from vertical vein. Again, the patient was diagnosis was given as supracardiac TAPVC. They continued the pregnancy. After baby's birth, if it 2D was done, the diagnosis was confirmed like obstructed supracardiac TAPVC at around 1 month of age of baby. But before they could do anything, baby suddenly landed up in distress and could not be survived. Now we'll move on to the second type of TAPVC, that is cardiac type TAPVC. In cardiac type, pulmonary veins connect to coronary sinus, which then becomes dilated and drains into right atrium. Or sometimes pulmonary veins drain directly in the posterior wall of right atrium. It is second most common type. So there are two types. Cardiac type, pulmonary veins drain in the coronary sinus. These are pulmonary veins joining and draining in the coronary sinus, which drains in right atrium. Or sometimes they directly connect with the posterior wall. This is type 2. This is again case 3, anomaly scan at 20 weeks, 3 days of gestation. This is just image to show the clear, smooth posterior wall of left atrium. Normally, we should see pulmonary veins opening in the posterior wall. This is colored scene of the same. Grossly, we see we can initially we think that all the pulmonary veins are opening in the left atrium directly, but here we can see dilated coronary sinus which is getting drained by pulmonary veins. In this patient, there was one PLSVC was also seen along with cardiac type TAPVC. We will see in further scene. This is grayscale scene. See, here is a fourth extra vessel and dilated coronary sinus. So initially it was thought that dilated coronary sinus was because of this PLSVC. But later, when again it was the thorough scan was done, it was noticed that there are pulmonary veins are rather opening in coronary sinus. That's why it is dilated. Again, this scene is just to show direction of flow, because to confirm that this is LSVC. It is direct. The flow is directed towards heart. This is slow scene. Notice dilated coronary sinus. Pulmonary veins are opening in coronary sinus. So diagnosis was given as intracardiac type TAPVC. Parents didn't do anything further. They continued the pregnancy, and after delivery, they were advised echo as soon as possible. But because they saw baby was fine and they thought there is nothing abnormal in the baby, so they didn't do anything. They went to cardiologist at around 6 when baby turned around 6 months. Then also they were advised echo. That time echo was done and diagnosis was confirmed that it was intracardiac type TAPVC. So surgery was planned, but before surgery could happen, baby landed up in distress and unfortunately could not be survived. Now we'll move on to the third type of TAPVC, that is infracardiac TAPVC. In this type, pulmonary veins form confluence behind atria. It is connected to anomalous descending vein that accompanies esophagus through diaphragm and drains into portal venous system, which then ultimately drains in IVC and then to right atrium. Venous obstruction is very common in this type of TAPVC. Okay, pulmonary veins form confluence behind atria. Confluence is connected to anomalous descending vein, which drains in the portal venous system, which drains in ultimately IVC and right atrium. So this is intracardiac type 3 of TAPVC. This is anomaly scan at 21 weeks of gestation. This this case was already discussed by Yogesh sir. This is the same case. The pulmonary veins are seen forming confluence behind atria, which goes down, which is seen descending in the towards abdomen. So here is that descending vein joining uh, IVC. Okay. The same case, parents continue the pregnancy and the follow-up was done at 34 weeks. Here we can see retrocardiac space is increased. Size discrepancy was slight size discrepancy was seen. Right chambers were appearing slightly dilated as compared to left. This is again to show the descending vessel. Here we can also see aliasing because of mixing of the mixing of blood. This is to point out the aliasing only. See, this is that vessel. The patient they continued the pregnancy, and as it was already diagnosis was already given and they were ready beforehand, so they planned surgery like on the next day, on the second day of baby after baby's birth. So the surgery went well and baby is right now 5-6 years, male baby, doing good. The fourth and least common type is the mixed type TAPVC. In this type, left pulmonary veins drain in the left brachiocephalic vein through vertical vein, and right pulmonary veins drain into coronary sinus or directly into right atrium. It is very rare type. Now, till now, we have seen all the cases of TAPVC at around anomaly scan. But is it possible to diagnose TAPVC in early pregnancy at the time of NT scan? We'll see. So this is NT scan image of NT scan scene of the normal heart. We can nicely see all four chambers, pulmonary veins opening properly in the left atrium. Okay. Now look at the right-sided scene. We can't normally properly see four chamber of the heart. Again, we can see single outflow tract, and no proper pulmonary veins are not properly opening in the left atrium. Rather, some anomalous, some confident vein like something is seen behind atria, right? So this is the same case. It was situs ambiguous with AVSD, single outflow tract, and supracardiac TAPVC. Diagnosis was given, and parents terminated the pregnancy. Now we'll move on to the PAPVC, that is partial anomalous pulmonary venous return. It is characterized by direct or indirect anomalous drainage of one, two, or three pulmonary veins into right atrium. It is difficult to detect antenatally. It is sometimes associated with Scimitar's syndrome. Scimitar's syndrome is a combination of right lung hypoplasia, hypoplasia of right pulmonary artery, and PAPVC. This is case 6. Patient came for anomaly scan at 19 weeks of gestation. Four chamber view grossly normal. Left sided pulmonary vein are seen opening at the left atria, but right sided pulmonary veins are seen opening in the right atrium. So this is partial type. Few vessels open on the left side in left atrium like normal, and few vessels open in the right atrium. So this is one more scene. Here we can appreciate it better. These are right pulmonary veins seen uh, turning downwards and then opening at the subdiaphragmatic vestibule. This is subdiaphragmatic vestibule. On the left side, left pulmonary veins are seen opening in the left atria. Right pulmonary veins are going towards subdiaphragmatic vestibule. This is ductus venosus. These are hepatic veins. Again, one more image to show superior and inferior pulmonary veins on right side. Right superior pulmonary vein, right inferior pulmonary vein going downwards and opening in SDV. They follow up, diagnosis was given, and they didn't continue the pregnancy. It was terminated. This is case 7, 21-weeker baby came for anomaly scan. Normally, we should see pulmonary veins opening at the left atrium. This is known as Moustache sign. In yeah, whenever there is, we can't properly see be some abnormality in the pulmonary venous drainage. So again, here also it was left pulmonary veins draining in the left atria, and right sided pulmonary vein are seen opening in the right atria. So this is PAPVC. Okay, the follow-up unfortunately was not available for this patient. Management. Once APVC is diagnosed, proper counseling should be offered to parents. For PAPVC, surgical correction is indicated with development of symptoms, significant left to right shunt or right ventricular dysfunction. Otherwise, conservative management with close follow-up is advisable. Corrective surgery is needed in all patients with TAPVC as soon as possible once patient is clinically stable. My take-home message is failure to see normal connection of pulmonary veins to left atrium is the key to suspect APVC. And understanding APVC is important because eyes only see what mind already knows. Thank you.